Here is a comprehensive breakdown of the anatomy and physiology of coronary circulation. The coronary circulation consists of the blood vessels that supply the heart muscle, that is the myocardium, with oxygen and nutrients, and those that remove deoxygenated blood. It is primarily divided into the arterial supply and venous drainage. Arterial supply. The heart is supplied by two main coronary arteries that originate from the root of the aorta just above the aortic valve, that is at the sinuses of Valsalva. Left main coronary artery, LMCA, is typically short and bifurcates into two major branches. Left anterior descending, often referred to clinically as the widowmaker when blocked at its origin. It courses down the anterior interventricular sulcus. It supplies the anterior wall of the left ventricle and the anterior two-thirds of the interventricular septum, the apex and the bundle branches. Left circumflex courses along the atrioventricular groove towards the posterior aspect of the heart. It primarily supplies the lateral and posterior walls of the left ventricle and the left atrium. Right coronary artery originates from the right aortic sinus and travels down the right atrioventricular groove. It typically supplies the right atrium, the right ventricle, the sinoatrial node in about 60% of people, and the atrioventricular node in about 90% of people. Coronary dominance. This is determined by the artery that supplies the posterior descending artery, which runs in the posterior interventricular sulcus and supplies the inferior wall of the left ventricle and the posterior third of the interventricular septum. Right dominant, 70 to 80%, the PDA arises from the RCA. Left dominant, about 10%, the PDA arises from the left circumflex. Co-dominant, 10 to 20%, the posterior septum is supplied by branches from both right coronary artery and left circumflex. Venous drainage. Deoxygenated blood is returned to the right atrium through three main pathways. The coronary sinus, the primary collector of venous blood from the left side of the heart. It sits in the posterior atrioventricular groove and empties directly into the right atrium. Major tributaries include great cardiac vein, middle cardiac vein, and small cardiac vein. Anterior cardiac veins. These drain the anterior right ventricle and empty directly into the right atrium, bypassing the coronary sinus. They may occasionally drain into the small cardiac veins. Thebacean veins, venae cordis minime, minute veins that drain directly into all four cardiac chambers, though most notably into right atrium and right ventricle. They contribute to a small physiological right to left shunt. Physiology of the coronary circulation. The myocardium has a continuous, extremely high demand for oxygen. The physiology of the coronary system is designed to meet this demand under varying conditions of physiological and emotional stress. Phasic blood flow. Coronary blood flow is not continuous. It is highly dependent on the phases of the cardiac cycle. Left ventricle. Blood flow to the left ventricle occurs primarily during diastole. During systole, the strong contractions of the thick LV myocardium compresses the subendocardial blood vessels, dropping arterial flow to near zero. When the ventricle relaxes during diastole, the compressive forces are released and maximum flow occurs. Right ventricle. Because the right ventricle pumps at a much lower pressure, the compressive forces during systole are less severe. Therefore, blood flow to the right ventricle remains relatively continuous throughout both systole and diastole. High oxygen extraction. At rest, the myocardium extracts 70 to 80% of the oxygen delivered to it by arterial blood. Because extraction is nearly maximal even at rest, the heart cannot simply extract more oxygen if demand increases, unlike skeletal muscle. Therefore, the only way the heart can meet increased metabolic demands, example during exercise, is to significantly increase coronary blood flow. Autoregulation and metabolic control. Coronary blood flow is tightly coupled to myocardial oxygen consumption. This local autoregulation overrides other systemic signals. Adenosine. When myocardial oxygen demand outpaces supply, ATP degrades to adenosine. Adenosine is a potent vasodilator that acts locally on the smooth muscle of coronary arterioles to increase blood flow. Other metabolites. Hypoxia increases carbon dioxide, hydrogen ion, potassium ions and nitric oxide. Also contribute to local vasodilation to ensure flow matches demand. Autonomic nervous control. While metabolic control is the primary driver of coronary vascular tone, the autonomic nervous system plays a secondary role. Sympathetic stimulation. Activation of alpha-1 receptors causes vasoconstriction, while activation of beta-2 receptors causes vasodilation. However, sympathetic stimulation also increases heart rate and contractility, beta-1 receptors on the myocardium, increasing overall metabolic demand. This local metabolic demand triggers the release of vasodilators like adenosine, which completely overrides the direct alpha-mediated vasoconstriction, causing active hyperemia. Parasympathetic stimulation. Vagal nerve stimulation mildly dilates the coronary arteries, but its primary effect is slowing the heart rate, thereby decreasing overall oxygen demand and ultimately reducing total coronary flow.